Today we have Dr. Wajiha Ahmed. She is an associate research scientist at NYU Langone's Alzheimer's Disease Research Center. She received her medical degree from Foundation University Medical College in Pakistan and earned a master's in clinical and experimental pathology from Case Western Reserve University. Her research focuses on comprehensive diagnostic strategies for Alzheimer's disease, particularly in early screening and monitoring. She is dedicated to identifying targeted biomarkers to support early detection and personalized management across diverse populations, ensuring equitable and effective care for all. And with that, I will turn over to Dr. Wajiha Ahmed.
Thank you so much for that introduction, Ahmed. Thank you so much. And thank you all for attending this seminar. I really appreciate you all having here. So today we're going to be discussing how disease-modifying therapies and research are transforming the future of Alzheimer's disease. As Abhinav mentioned, I am very enthusiastic about finding early targets for diagnostics, monitoring, and therapeutic targets for management therapies. So this was something that I was really excited to present. Um, our goal today would be to understand how Alzheimer's disease develop and how new treatments aim to slow down the disease process or halt it. So one thing that we'll clarify over here is that the central nervous system, it does not have a lot of regenerative ability. So once the damage is done, the neurons are not, it's difficult to regenerate any neuronal life back. So that's why it's important to manage or treat or diagnose the disease early on where the damage is minimal. Now, how did Alzheimer's disease started? Well, as we go back in 1900s, memory loss or dementia was actually thought to be part of normal aging. It wasn't considered a separate disorder on its own. But 1901, Alois Alzheimer's got interested in this 51-year-old patient, August Dieter, who was coming with memory deficits and cognitive decline and memory dysfunction. And it was kind of rare to see that in a 51-year-old. So he started following up with her and started treating her. Unfortunately, she passed away in 1906. So he performed a brain autopsy on her and he found that there were some clumpy, sticky proteins and some twisted fibers in her brain tissue. And those were the amyloid plaques and these tau tangles. So he presented his findings in a conference that same year, and he suggested that memory loss is actually a disorder on its own and not just part of normal aging. In 1910, Alzheimer's disease was founded as a disorder of its own, and memory loss was not considered part of aging, and it was named Alzheimer's disease to honor his Alois Alzheimer's legacy. And since then, we have had transformative changes in detecting, in treating, in raising awareness of Alzheimer's disease. So, what are the hallmarks of Alzheimer's? I think a lot of you would already be very familiar with this. It's amyloid beta, which is a normally occurring protein. It's regularly floating around in normal human beings as well. But some things happen that make it clump together and form plaques that are the key marker of Alzheimer's disease. And then the other hallmark is tau tangles. These are also normal protein that are physiologically present in our brain, but due to some changes, they structurally get so distorted that they start to twist over each other and form tangles. The body recognizes this as a foreign body now because they don't look like the structure they should. And that results in a lot of inflammatory processes that kick in. And in the immune system in the nervous system is separate from the immune system in the rest of the body. So cells like microglia and astrocytes start to get activated in the brain and cause inflammation. These tangles and plaques also result in a lot of cellular dysfunction, which results in synaptic dysfunction. So synaptic dysfunction occurs when synapses are when neurons are communicating with each other and making sure that everything is running smoothly. You're thinking smooth, your actions are smooth, your motor function is smooth. But when there is a dysfunction in this communication, that alters how we think, how we make memories, or how we act. And then it all pans down eventually into loss of the neuronal death, and axonal injuries. And that manifests as neurodegeneration. So over here we see a normal brain, looks very healthy, is very voluminous, and look at these nice neurons. And but over here, when we see the Alzheimer's disease section, we see that the brain has already atrophied. The brain volume has shrunk down, and there are these abnormal deposits in the background of the neurons, outside of the neurons, and those are the plaques. And then we see that there are a lot of fibers running in the neurons, and those are the tau tangles. Now, what have we done over the years to detect Alzheimer's, right? How has that evolved? In the beginning, in the 1980s, we were just looking at brain tissues when people would pass away and we anticipated they had Alzheimer's. We would look, so the diagnosis only happened after death because we could only do an autopsy, look at the brain tissue, and confirm there were amyloid plaques and there were tau tangles. And then if you look under immunohistochemistry, you would find changes of synaptic dysfunction. So from that to come to 1992s and 1990s, basically, a natural progressive route was to look at the CSF. Now, what is the CSF? CSF is the cerebrospinal fluid that encompasses the central nervous system. So it's very closely in touch with the brain tissue, with the the neurons. So, and it is a the function of cerebrospinal fluid is to take away the toxic metabolic waste and excrete it in the systemic circulation. So this was a natural next modality to see if we can find these markers in the CSF. This was still very invasive. So we moved on in the 2000s to imaging, neuroimaging. So there are different kinds of imaging that can be done. They can be MRIs, they can be PET scans. So I know some of you are part of the study over here, and you would know we do amyloid PET, tau PET, and then functional diffusion gradient PET, MRs, and that's what we look at. And now what we also do, as you would know, is the blood biomarker. So this, again, imaging was very expensive and CSF was very invasive. So now the future is blood-based biomarkers. In the blood-based biomarkers, it's less invasive, it's economical it is easy to implement, and we can still find all the biomarkers that we were looking for in the brain, in the CSF, and on the imaging. We can find traces of it in the systemic circulation and in your blood and plasma. So that's why we take a lot of that blood from you when you come for our study. All right, so let's talk about the AD continuum. So we're going to talk about in this schematic how different detecting tools become detectable at different phases of the disease. So AD has three phases. The preclinical Alzheimer's disease has three phases. The preclinical phase, where you're cognitively normal or may have subjective cognitive decline. Then it's a mild cognitive impairment, and then it's dementia. So for the major part of that continuum, people don't have any symptoms. They don't have any memory deficits or cognitive decline or cognitive impairment. So over here, when we see the first thing that becomes detectable in this silver line, we can see is the amyloid beta 42 in the cerebrospinal fluid. And that makes sense because there's a lot of amyloid beta 42 being produced. And now it has to be excreted out. So it gets excreted out into the cerebrospinal fluid. And then that fluid, when we test it, we can see traces of it. Now, once the fluid reaches its capacity and is maxed out at taking out that amyloid beta, it starts to accumulate in the tissue in the brain. And that is detectable by the PET scans. once that accumulation starts, it's causing a lot of cellular dysfunction, synaptic dysfunction, and that is going to be detectable by those diffusion gradient PET MRIs or functional MRIs. There is a leading theory that once the amyloid plaques have deposited, they actually interfere with the tau metabolism that result in tau becoming misfolded and forming tangles and cause further neuronal injury and cellular dysfunction. And that becomes apparent after the synaptic dysfunctions. And then when you look for CSF, tau would become positive after that point. And from that point onwards, because the damage is so much, the neuroinflammatory processes have taken so much in that the neurons start to die and the brain volume starts to shrink, and that could be appreciated on MRIs. And once the brain volume starts to shrink, the neurons are dying, cognitive impairment or memory symptoms start to appear. And eventually they lead to like very decreased functionality. And then over here, we will see how doing imaging was a game-changing diagnostic modality in managing Alzheimer's. So over here, we have three different panels, and this would also kind of give you an overview of the scans that we do over here when you come and are part of a study. What are we looking at? So there are two kinds of scans that we are showing over here. This is an MRI, and this is a PET scan. So what is happening over here is we're going to see how the progression of the disease can be followed on these neuroimaging scans. This individual, A, is cognitively normal. And because they're cognitively normal, their MRI looks good, but also let me give you a key before that. So the more yellow and red you see, the more A beta or amyloid has accumulated in the brain tissue. So over here, we see like it's very few areas where amyloid is accumulated. And so this is somebody who's cognitively normal. They don't have any accumulations, and their MRI is also showing no atrophy or structural changes. But then somebody who has, let's say, SCD or MCI, then or SCD actually, who's having subjective cognitive decline, but they're cognitively normal. They don't have any memory deficits as of now. Their MRI would still look the same as that of somebody who's completely normal. But once you see their PET scan, you're going to start to appreciate a lot of amyloid accumulation in different areas. And then this scan shows someone who's already diagnosed with Alzheimer's disease, and we can see that there's a lot of amyloid that is accumulated in their scan, in their PET scan, and the damage is so severe in this case that it is actually also showing up in the MRI where the brain volume has started to shrink, as you can see over here, here, and here. All right, so this is just a quick overview of how imaging is helping us diagnose early. Now, what are the leading hypotheses that are, feeding into the pathophysiological processes that happen in Alzheimer's? So there are three main hypotheses: cholinergic hypothesis, amyloid cascade hypothesis, and tau hypothesis. So cholinergic hypothesis now is more of a hypothesis of the past. It was very famous. It was very popular in 1970s and 1980s, where one of the neurotransmitters called acetylcholine was getting, there were low levels of acetylcholine in people who had Alzheimer's. So it was assumed that it has something to do with it, which it did, but it wasn't a causative factor. It was actually just an effect of the disease processes that were causing Alzheimer's. We're going to talk more about it later. And then it's the amyloid cascade hypothesis, which is still presently very popular. And that's why we have so many anti-amyloid therapies that we're going to speak about and that we're going to discuss later on in the slides. And then the tau hypothesis is more of a hypothesis of the future where we are trying to target tau and see if there is a lot of amyloid accumulation that's causing cellular dysfunction that's leading to tau hyperphosphorylation, which in turn causes neuronal death. So if we can target tau, that could also be very helpful. So in the past, as we spoke about the cholinesterase, right? So the acetylcholine was a neurotransmitter that was being generated by neurons that were located in the hippocampal and cortical areas. Now, during Alzheimer's, as neuronal death was occurring, these neurons were dying. So the acetylcholine levels became lower and lower. The natural approach was, okay, what can we do to increase these levels? And acetylcholinesterase inhibitors were developed, like donepezil, rivastigmine, to increase these levels. So these improved the symptomology, but they never really addressed the main cause that was causing this neuronal death. So that's why a lot of the focus shifted from the cholinergic hypothesis to amyloid hypothesis. Now, what is the amyloid hypothesis? So this is an amyloid cascade, okay? Now, amyloid can be affected in two different ways. So the Alzheimer's disease could be familial or it could be sporadic, right? So if it is familial, that means that it is occurring due to some mutations that you're carrying in your genetic system. So it could be mutations like missense mutation, duplication mutations in genes that are responsible for forming amyloid precursor protein. So it could be APP gene or PSEN1 or PSEN2. And then the sporadic form of AD, that occurs due to your environmental factors. And if there's another genetic risk factor like having ApoE4 homozygous or heterozygotes. So what happens in the familial part of the disease is that protein that is being formed, the amyloid beta, is very it's not in the right structure that it should be. So it starts to misfold and gradually accumulate because it has nowhere to go. And then it starts to aggregate within the nervous tissue. In the sporadic form, there is decreased clearance of amyloid beta. So that results in the gradual accumulation of amyloid beta in the tissue. Once this accumulation starts, these amyloid beta fibers, they come together, they clump up, and they start to form aggregates, which could be called oligomers. Now, these oligomers are still soluble form of the plaque. The soluble form means that it can cross the cell membrane and go into your neurons. And once it goes into the neurons, it causes a havoc in your cellular system. So your cellular functions go into a disarray. All the normal metabolisms are thrown out the window, and that also affects your tau metabolism and results in tau misfolding and tau tangle formation. Once they forms oligomers, they form protofibrils, and they just starts to clump up into these really big senile plaques. This results in activation of the neuroinflammatory systems like the astrocytes, the microglia, and eventually they result in this altered neuronal homeostasis and synaptic dysfunction, and which eventually results in, as we discussed, neuronal death. And once the neuronal death starts to happen, that's when cognitive dysfunction and cognitive impairment and dementia symptoms actually start. So that meant that amyloid was a good target for this therapy because it was driving the entire process. So a lot of the trials that happened early on started focusing on amyloid. But then over here, you see most of them failed. And that was because of lack of efficacy. It wasn't targeting. The treatment was not, um, working until 2020, where we have aducanumab. Aducanumab was the first drug that got actually FDA approval. It's discontinued now, but it was the first drug that got FDA approval and that showed efficacy, treatment efficacy. So why did all these trials fail, right? These trials failed because in the beginning, we were just taking everybody in the trial. It didn't matter. We were just seeing if they had symptoms, we would take them in. We weren't making sure that this person actually had Alzheimer's. So that diluted the results because we were trying to target a protein that's not available. So that's not going to change any symptomology. And then there was a patient heterogeneity that even in dementia, there are different kinds of dementia. There's vascular dementia, there's frontotemporal dementia, there's so non-AD dementias were not being amyloid was not the key role player in their pathology. And then there was lack of biomarker use at the point because none was available or it was too expensive, too invasive. And that also resulted in a lot of amyloid negative people getting recruited for those trials. And we're trying to target something that's not present in these people. So that was one of the biggest reason why these trials were failing. Then these trials were only looking at people who had Alzheimer's, who had symptoms, memory symptoms, or who had diagnosed Alzheimer's disease or cognitive impairment. And by that time, it was too late, as I discussed, that the neurons are not going to regenerate. So even if you end up stopping the disease process at that point, but there's enough damage that has occurred for treatment to show any efficacy. So now what are we doing? How are we doing it better? We are focusing on by using different biomarker analysis, right? So we are taking PET scans into account, spinal fluid into account, blood fluids into account, and making sure that people who have amyloid and tau are being recruited for these drug trials and early on. So they're now being recruited in the earlier phase when they're in the cognitively normal or preclinical phase of the disease or even MCI. So all these anti-amyloid therapies that are working now are actually targeting this population. All right. So what disease-modifying therapies are? Disease-modifying therapies are where we are going to change the course of the pathological processes that are taking place. We're going to halt the underlying cause of the disease, right? So in this case, we're going to be discussing anti-amyloid therapies, which are monoclonal antibodies that are going to target your amyloid plaques. And the two we are going to discuss today are both FDA approved. So it's Lecanemab or Lecanemab or Donanemab or Kisunla. So this is how, once the abnormal amyloid beta is released, it forms monomers and oligomers and protofibrils and fibrils, and then all of them just clump together and form this big senile plaque that has nowhere to go and is like causing so much inflammation in the brain. Different drugs actually try to, target different areas of this cascade, right? So lecanemab is trying to target the oligomers. And as I discussed, the oligomers are actually soluble. So they are the ones that are causing so much cellular damage and activating your immune system, your neuroimmune system. So if we can target them, we can actually harness and kind of control the inflammation that's taking place in the brain due to plaque formation. All right. So coming down to lecanemab. Lecanemab is a monoclonal antibody. It targets the plaque formation midstream. So as we said, it's going to target the oligomers, the soluble aggregates, right? And then it is going to activate microglia to just kind of engulf all of them so that they would not go on to form senile plaques. And they would not also cross the cell membrane and go into the cell or neurons and cause cellular dysfunction, synaptic dysfunction, and inflammation. Now, there was the trial that tested this drug, Clarity, showed that there was significant slowed cognitive decline in these people. And the PET scans shows that A beta accumulation was like predominantly reduced in these people. And it got its FDA approval in 2023. The next drug that we are going to discuss is Donanemab. So Donanemab is a target specific form of it targets specific form of the plaque, which is pyroglutamate modified amyloid, which is only seen in this form of the plaque, which is the mature senile plaques that are, just present extracellularly. So the trial that was looking and studying donanemab was Trailblazer Alzheimer's trial, and through it we saw that there was significantly reduced amyloid accumulation on the PET scans, but also the cognitive decline and the functional decline was slowed down in these people who were receiving this treatment. So a little bit more about lecanemab, I should also mention is that it is a treatment that goes on for 39 months, and people who go for the treatment, they receive an IV infusion of the drug every 2 weeks. So donanemab, on the other hand, is every month people would receive an infusion, and this goes on for 12 months. So here we are, but then, so what are we doing over here? We're using these immunoglobulins or antibodies to, you know, attack the plaques and take them out of the system, right? But what happens is, because these plaques are now being taken out, they were also located in the vessels. So once we take those plaques out, that leaves the vessel wall very, very leaky and sort of like weakens the wall of the vessels. Once that happens, then we have these side effects that are associated with these anti-amyloid beta therapies, which are amyloid-related imaging abnormalities or ARIAs. So what happens in ARIAs is that once the plaque is removed, the vessel wall becomes leaky and very weak and starts to leak fluid out into the interstitium. And that is seen as swelling or edema. And then sometimes the vessel wall is so weak that it actually just like bursts out and we have microhemorrhages. So these are microhemorrhages that you can see over here. So we currently are also planning on doing a study where we can um, detect these ARIAs. So these ARIAs right now are only detectable through MRI screening. So people who are receiving these treatments, they have to undergo MRI screening and multiple times, so frequently, right? But that's expensive and it's also time consuming. So we are trying to see if we, through our study that is Monitor AD, we can actually see these ARIA, the changes that can occur in the brain chemistry that would lead to ARIA development in the blood, and preemptively see if somebody is going to develop ARIAs, and we can titrate the treatment, we can stop it, or we can wait for them to like recover from it or their vessel wall to become healthy again, and then reinstate the treatment. All right. So now we'll talk about the future. So what is the future? So I remember we talked about cholinergic hypothesis, amyloid cascade hypothesis. The future is the tau hypothesis. So once this amyloid starts to accumulate and the oligomers start to cross the cell membrane and go into neurons, they cause cellular dysfunction, which interferes with the metabolism of tau proteins. So now tau proteins are forming tangles because of that, and they are not able to, they get hyperphosphorylated because there are some enzymes that phosphorylate them, but now they're getting a lot of these enzymes hyperphosphorylating them. So that becomes an issue, right? So amyloid, what the belief right now is that although amyloid starts this disease process, but tau is the actually culprit that is driving this disease process by causing inflammation, cellular dysfunction, synaptic dysfunction, and eventual neuronal death. So the culprit for neuronal death is actually tau. The plaques just put it into that motion, put that cascade into motion. But why is it harder to treat tau, and why has it not been already done? It's because it's located intracellularly. So we have lower access to it. Our access is blocked by the cellular membrane, first by the blood-brain barrier, and then by the cell membrane. So there are a lot of trials that are looking into different modalities to target tau. So they are targeting tau aggregation inhibitors and then anti-tau monoclonal antibodies, just like we have anti-amyloid antibody treatments. For future, what we are looking into is how we can stop this amyloid to tau cascade, if we can target that and cause a kind of halt that phase of the disease. Block tau spread from neuron to neuron. So because tau, once it gets affected, like prions, it starts affecting other neurons that are surrounding it. and how we can target the tau aggregates that have already formed intracellularly. So these are the three future targets for Alzheimer's disease. And then neuroinflammation is also being studied very enthusiastically because, immune system is supposed to help us, right? But in the early stages, it is doing that. It is helping us clear amyloid and tau, and it is helping us to remove those harmful proteins. But it just happens that because that inflammatory process keeps going, because amyloid is still aggregating, that it gets out of control and it becomes more harmful. And that starts to damage the brain. The normal surrounding brain tissue of the plaques also starts to get affected in that. So our idea over here is how can we harness this neuroimmune system to work as an ally for us and kind of help us guide it in a way that it would be able to that the activation is controlled. And then over here at the NYU Alzheimer's Disease Research Center, these are a few modalities that we are studying. It is one of the more than 30 centers that was established in 1999. You've pioneered a lot of stagings of Alzheimer's disease, especially in the early phases of the disease, like the preclinical, the SCD, and the MCI. A lot of you who come down know a lot of the testings that we do were actually, they were developed here, in the center. And then we were also pioneer in establishing the use of imaging to diagnose early stage of AD. We currently have more than 500 older individuals in our longitudinal study who come in every year for their annual evaluation. This one, we really appreciate our volunteers who come in because this helps us collect this very meaningful data and look at it over the years and see how things are changing. And that is really, making a difference in how we are looking at disease processes in Alzheimer's. Now, our goal over here is to create faster, cheaper, and easier tests that can spot Alzheimer's as early as possible. We are also working on, like I mentioned, monitor AD in ways or tests that can predict or prevent the ARIAs that are related to anti-amyloid therapy, like Lecanemab or Donanemab. And we also have studies going on that are looking into tau. How can we better target tau? And how can we harness the immune system? And how can we make the synaptic dysfunction that is taking place? How can we sort of, stop that compromisation of the synaptic system? So what are the take-home points from this? The take-home points here are, if you can act early, that will change everything. If you can detect it early, we can monitor it. We can monitor it, we can treat it early. Because once the damage is done, it's harder to go back. But if we can control that damage in the earlier stages of the disease, that would be great. What next? Anti-amyloid therapies are finally working because the trials have been designed to treat and recruit right people and see the effect of those drugs. And then they are working, but they still have a lot of side effects that are associated with them, right? So we are working on designing studies that could help us reduce those side effects. And then we are also trying new cutting-edge therapies that can empower our participants and our patients to diagnose and have more personalized management plans and change what is possible as the future of Alzheimer's disease if we can, And that's it. Thank you.